Thank you very much, everyone, for coming back from tea. I thought maybe a few people will disappear, but you haven't. Everybody's here. Okay, so this is much awaited session on urodynamics. We have been talking about urodynamics so much, and the purpose of this talk will be to make it very simple and easy and to make you all understand what does it involve. So we will talk about indications of urodynamics. We will talk about what's the technique for urodynamics, how do we interpret, and clinical utility. As you will all expect, it is not something which you will understand each and everything, but shall we take it as a starting point? So you have basics of it and then you can build on it. Because that was the topic when I was a trainee, I hated it because when you read it from the book you don't understand anything. It's very, very confusing and you say, oh my god, how I'm going to manage that. But once somebody teaches you exactly the way we were talking about PopQ, when you read it yourself it sounds really difficult, but when somebody teaches it and simplifies it, it becomes easier and simpler. So we will talk about why do we have to do urodynamic investigation, what's the purpose of it. Before I read that out, the reason is because so many of the symptoms of urogynecology are interlinked, and so many of the bladder symptoms are very, very confusing because sometimes patients are not good historians and sometimes they can't describe it, what they are feeling. For example, somebody requested me to see two patients yesterday. So I was talking to them, and what I was trying to get out of them from their history, I noticed that I was not able to get from them because they were telling me in very, very, very vague words what I wanted to hear. I was not getting that. So such type of patients, most likely my assumption was that they have got mixed urinary incontinence. So that is my assumption. But treatment of mixed urinary incontinence, how do you treat them? Do you start them on overactive bladder treatment? Do you offer them surgery for stress incontinence? Or you start both? But in urodynamics, we can find out what is the actual diagnosis and what is the dominant symptom, what is causing more leaking. And that way we are likely to treat the cause which will make patient better. So it is a functional assessment of lower urinary tract to provide objective pathophysiological explanation for symptoms and or dysfunction of the lower and upper tract, and it comprises a series of tests. So in simple words, what I tell my patients when I'm going to request urodynamics, that when we do a scan, ultrasound scan of the bladder, or when I put a camera in the bladder, I look at the structure of your bladder. So how does bladder look? How is the dome of the bladder? Where are ureters? Where is trigon? Is the bladder big, small, any ulcers? But it tells me nothing about function of your bladder, that how does the bladder work. For example, if you take example of stomach and you look at the anatomy, it may look perfect when we look at it, but how does it function? That can give rise to various type of diseases. Similarly, when we put a camera in the bladder, do scan, it may look normal, but actually we need a functional test, and this is what urodynamics provides us. So urodynamic testing has various parts. And the first part is patient has to do a bladder diary. Yeah? Shall I stop? Azan is going on. Just for a few minutes. So I just noticed. Sorry. So here we have mentioned uroflowmetry. Even before uroflowmetry, the first part of the test is the bladder diary. We'll talk about it, which patient has to fill in 3 days before the test. So we provide her bladder diary and we tell her for the 3 days you need to buy some cheap plastic jug and you need to pass urine into the jug. So we know exactly how much urine she is passing, and then she has to write against time how much urine she passed, maybe 7 o'clock, 9 o'clock, 12 o'clock. All the time for 3 days she passes urine in a jug. She measures exactly how much it is and she puts in the bladder diary. The second thing which goes, whatever she is drinking, for example, I just had like 50 mils of water, I will write, okay, at this time I had this much water. I had a cup of tea, I'll mention that. And also she will mention how many times she had leaking of urine and what time was it. So this is called bladder diary. So that is the first part of the test. And before that, we tell patients, usually in my practice, although latest guidelines, they don't put pressure on this point, if someone is taking any anticholinergics or any mirabegron or any medication to improve her bladder, I give them advice to stop it 2 weeks before the test. So we have the actual picture. So that is my standard practice, which has been traditional practice. But in the latest guidelines, they say if they don't stop medication, even then it's all right. But my patient, I tell them to stop medication. So we have unbiased results. So the first part mentioned here is uroflowmetry. This is a subject in its own. We'll talk in detail. Twin channel subtractic cystometry, that is the actual urodynamics test. Then voiding cystometry. Then we will have a little mention about video urodynamics. They are not available in each and every hospital. They are only available in very specialized tertiary hospitals. Urethral pressure profile and ambulatory urodynamic monitoring. So out of all these, if you only understand what bladder diary is, what is uroflowmetry, and what is twin channel cystometry and voiding cystometry, that is enough for you. So you don't have to do anything with video or UPP or ambulatory. So that is for specialist units. So basic learning, bladder diary, flowmetry, cystometry, and voiding cystometry. Only 4 things. Okay, so this chart I included for your reference later on. It is a busy slide. Dr. Seema has just left. Can you read it? Before she was saying that slides were not very clear. Is it all visible? It's clear. Okay. So the type of, there are few things, little explanation, but this is for your reference. So cystometry is a storage function of the bladder and sensation of the bladder during the filling phase, and indicated in patients any incontinent subject to be investigated for their dysfunctional condition. Okay, so cystometry, cysto means bladder, metry means study. Okay, study of the bladder. And urethral pressure measurement, urethral closing forces, and if there is any problem with the urethral sphincter problem, if we are suspecting that, we do that. Rest of all, I wouldn't worry for it for now. It will make you confused. Let's explain the test first and then we'll go back to it. So after taking history examination, we can do cystometry in women who have any of the following: urge predominant mixed urinary incontinence or urinary incontinence when the type is not very clear. Symptoms are suggestive of voiding dysfunction. If there is anterior or apical prolapse and there is history of previous surgery for stress incontinence. So these are the indication when we should do urodynamics. Okay, so before any surgical treatment for urgency incontinence, which is overactive bladder, if we are going to do any surgical treatment, only then we need urodynamics. But simple overactive bladder, for example, increase frequency, urgency, and urgency incontinence, which is straightforward and there are no complicating factor, there is no need of urodynamics. Okay, we can start them with pelvic floor exercises, bladder retraining, cutting down on tea and coffee, and we can try anticholinergic or beta-3 agonist. But if there are complex cases, and we want to do surgical management or conservative management has failed, then we do urodynamics. And the surgical treatment for overactive bladder is Botox treatment or PTNS we are talking about. So these are the 2 surgical treatment. We don't do very invasive treatment, which is clamp cystoplasty or augmentation cystoplasty, which is huge surgical operation. We don't do that. So when we refer to surgical treatment, it is either PTNS or it is Botox. Stress incontinence, if stress urinary incontinence is pure stress urinary incontinence, we can offer them surgery without urodynamics. For example, if a patient has only complaint of leaking when she coughs or sneezes, or when she's playing tennis, or when she's running. It is pure stress incontinence. Her daytime frequency is 5 to 6 and nighttime frequency is 0. She is able to hold urine and bladder capacity is big. There is no need of urodynamics. Pure stress incontinence without any indication of overactive bladder can be treated surgically, so we can offer them any surgical treatment we want. So this is the recommendation, nice recommendation. But in my personal practice, if I have to do any surgery for stress incontinence, for my own safety, I do urodynamics for each and every patient to have a thorough study and documentation before surgery. Then neurological urinary incontinence, like spina bifida, spinal cord injury, anorectal abnormalities. Before any surgical treatment, we would like to know a bit more. Children with urinary incontinence. Most of the time, when children have bedwetting or when they have overactive bladder, it is mostly pure overactive bladder, most of the time. Yeah. So if it is straightforward, anticholinergics and beta 3 agonists can be given to children under supervision of a pediatrician, but in smaller dosage. But we don't have any particular guidance. But only after before invasive treatment in children. I have done urodynamics for children as well, only if I'm offering them invasive treatment like Botox. So I've done a couple of Botoxes for girls who are like teenagers, not anybody below 12. I don't see anybody below 12. But normally we don't have any nice recommendation because that is for pediatricians. Frail elderly with urinary incontinence, there is no nice guidance, but ICI recommendation is only after initial conservative management and before invasive treatment or after failed treatment. So in summary, everybody needs urodynamics once they have had failed conservative management. And before we want to do any surgical or invasive management, they must have urodynamics for our safety and for patient safety. So that is a summary of this chart. Okay, so it guides us for treatment decisions and it helps us determine whether it is stress incontinence, it is pure or mixed incontinence. It also predicts surgical outcome. So it identifies patients at risk of persistent incontinence after surgery, particularly if they have both element. For example, they have stress incontinence, they have overactive bladder. So whichever element we choose, the other element may get worse after the other treatment. So that's what after surgery they may get worse. Complex cases like neurological bladder dysfunction, voiding disorders, and it monitors treatment efficacy, for example, post-operative and post-treatment assessments. Sometimes after Birch-Colpo suspension, that is one of those surgeries I don't like doing, and I don't do it because I do sling operation. But if patient has had Birch-Colpo suspension as now has developed severe voiding dysfunction, then we do urodynamics to assess post-operatively. Okay, now we have talked enough. Now let's do the actual job. So the first one is UKCS guidelines. Everybody should have access to UKCS guidelines, so you can check it online. And minimum standards to do urodynamics testing. Minimum standards mean it needs to be a dignified office room where there is no interference, no people are popping in and out. It should be dignified because it's very embarrassing test. So that is minimum requirement. It should be very clean atmosphere. There should be a changing room beside it, and there should be a clean toilet only meant for urodynamics patients. Yeah, and the room should have at least 3 compartments, so patient has dignified place to get change, go to the toilet, get change again, and have it in privates. So everybody before urodynamics must have urine dipstick done. Okay, because if somebody has undiagnosed infection, because we are putting 2 tubes in the bladder, it can make the infection worse. And if somebody has no infection at all, even then they have 1 to 2% risk of developing UTI after urodynamics. So we don't give antibiotics routinely after urodynamics, but we tell them you have to drink a lot of water when you go home to flush everything out, because 1 to 2% risk of infection. So for example, if a patient has come for urodynamics and a dipstick has shown nitrites and lots of white cells, I will not do urodynamics. I will give her nitrofurantoin for 3 days and I will bring her back. But if the patient will tell me, She came last time as well for urodynamics, and her urodynamics was postponed last time as well because she had nitrites and white cells. Then I'll go ahead and do it. Because some patients, especially after age 65, whenever you will do dipstick, they will always have white cell and they will always have nitrite because of low grade infection, because E. coli, they have hooks on them. So they get stuck. Oh, thank you, my darling. I have got it. Thank you very much. I got it. So they have E. coli have hook on their surface and they can get stuck to urothelium. And they produce low grade bacteriuria, and nitrites are always present in some patients. That's why we should never ever keep giving antibiotics to patients who are asymptomatic with very, very low grade nitrates and white cells. So sometime we can do urodynamics even when there is nitrates and white cells. So third is obtain verbal consent and analyze bladder diary for 3 days. So what bladder diary is going to tell us what is the total volume they are drinking. So we would expect an adult female in Indian environment, no matter it is winter or summer, at least drink 2 liters of water. Yeah, so you all can check tomorrow how much water you are drinking. At least 2 liters of water is absolutely essential even in winter. So in summer it would be 3 liters. It's not for beauty, it is an essential thing. So 1.8 liters is needed to clear all the toxins from your kidneys, but 2 liters is about right, and 2 to 3 liters summer and winter. So bladder diary will tell us, and actually you get surprised. So I decided to do my bladder diary 2-3 years ago, and I was shocked to find out that I was only drinking 1 liter of water in the whole day. And only after doing bladder diary, I realized that, and then I started drinking. Now I drink at least 2.5 liters of water, and it has not made me go to the toilet a lot more. It doesn't. It just makes me to have less muscle cramps and less aches and pains. So hydration is the key to avoid all these lethargic feeling. Inquire if the anticholinergic prior to the test have been stopped or not stopped, and then explain the test to the patient. Reduce the prolapse prior to the test. If somebody has a huge prolapse, a ring pessary can be put in before test. So the first and the most important part, which is least invasive, is uroflowmetry. So there is a special commode which is present in the office. So patient comes with a full bladder. She sits on the commode, and then this commode has a special jug underneath which is attached to the computer screen. So when she passes urine, the flow meter on the computer screen makes a graph like that. So it is a simple, non-invasive and relatively inexpensive test. It is objective and quantitative information as first line test. So patient is asked to void by relaxing and not straining while sitting on a commode over a rotating disc flow meter or weight transducer flow meter. The volume of urine passed per unit time can be assessed in milliliters per second or maximum flow rate and volume voided. Post-void residual volume is measured either with a catheter or with a scan. So in flowmetry, we can get a lot of information. What is the maximum flow rate per minute, and what is the average flow rate? So in females, let's see what is on the next slide. Peak flow rate, which is Qmax. This is what we would like to see. What is Qmax? So somebody with voiding dysfunction, her Qmax maybe will be 4 or 5 or 6. So very, very slow. Somebody with overactive bladder, Qmax will be 30 or 40 because urine will rush out. But somebody with prostatic hypertrophy, it will be maybe 2 or 3. So flow meter can give us a lot of information about Qmax. And normal Qmax, the level which we agree, it should be or it must be more than 15 mils per second in females and more than 20 mils per second in males. When we go for urodynamics training, usually there is a big center in Bristol where we get trained. So the examiner will say, I want all of you to sit on the flow meter and check your flow rate. And we said, why would you say that? He said, so that you can understand how humiliated a patient would be feeling in front of you. So he said, that's why I want all of you to sit there and pass urine. So it is a very embarrassing test. So that's why we need to give dignity and privacy, and we need to have a curtain around. And when we click the button that patient allowed to pass urine, we all step out of the curtain. So we don't watch her. So this is really important. That's why the setup is really important. So abnormal findings are low Qmax suggests obstruction or detrusor underactivity. Okay, so this is the curve, is a normal bell-shaped curve. That's what, if most of us will do a flow rate, that is the graph which we will get for us. So, some abnormalities of the flow. Even we have not touched the patient, we have not put any tubes in her, just doing the flow we can diagnose so much. So, first one is like episodic spiky flow. There are several peaks in Qmax, and it is caused by Valsalva maneuvers, straining, leading to fluctuating and intermittent stream. Possible causes are bladder outflow obstruction or unsustained detrusor contraction. If there is a stricture, there is prostate is enlarged, there is obstruction at the urethra because of huge cervical fibroid, or detrusor muscle is not working and patient is straining her abdominal muscle trying to pass urine, and then we see spikes like that instead of a nice bell-shaped curve. The next possibility is reduced Qmax. So you see, instead of like bell shape, this is like a box. So this is called a box flow curve. A rapid upstroke but reduced Qmax giving to a plateau shape. It is also denoting a urethral stricture, external urethral compression or bladder outflow obstruction with prolapse after continence surgery and failure of bladder neck relaxation or acontractile detrusor. So instead of a bell shape, we get like a box. Very, very high Qmax. So a rapid upstroke and downstroke. So possible detrusor overactivity, this is what we very commonly see in overactive bladder, high speed squirting to overcome an obstruction. But usually the bladder muscle is desperate to contract, as that's the reason they have urgency, okay? Because of urgency, they can't even sit down and the bladder pushes the urine down, so we see very, very high Qmax. So these are possible abnormalities which we can see in flow meter, and we have not even touched the patient and we have got a lot of information. Now the actual urodynamics is actual cystometry is a word which is used, the actual invasive phase of the urodynamics. The reason it is called urodynamics because it includes bladder diary, flowmetry and cystometry. That's why it is called urodynamics. So these are different parts. So cystometry is a part of urodynamics, but this is the most invasive part. What do we do? I will just tell you rather than reading that. So what do? We ask patient to lie down in lithotomy position and we clean her. Yeah. After that, we have a small sensor which is blue color. So it's color coded. So blue for bladder. So we remember that blue line is going into the bladder. So we put that blue line into the bladder. It is very long, like 2 meters long. So only that much, like 5-6 centimeters, goes into the bladder and urethra. Before, obviously, we have cleaned and given instiller gel. The second line which we put in the bladder is called filling line. It is just like a small catheter. It is around like 1 meter long. And then it is attached to the drip, which is attached to the beside my computer. So now I have two lines in the bladder. One is blue, which is for bladder, and one is the filling line. But when I put the filling line, I open it first before I attach to the drip to empty the bladder 100%. So at this stage, I diagnose post-void residual because patient has just been sitting on the toilet. And if I put a filling line, I should not get more than 20-30 mils of urine. But if I get 200 mils of urine or 250 or 300, sometimes 500, this is undiagnosed overflow incontinence. And that was the reason patient was having incontinence. So even before I have started, I have ruled out so many of the diagnoses. So that's why it is such a fantastic test that most of the time patient will get surprised. Oh, I just emptied my bladder and I have already got 300 mils. So there could be various reasons, and sometimes we can tell patient we already know what the problem is and that you do not empty. So, but we continue. We empty the bladder completely. So we start from zero, and after emptying with the filling line, I attach the filling line now to the normal saline drip, which is at room temperature and is attached to the side of the computer. And the third line is red line, red for rectum. Yeah, so we remember that the sensor, because it is really important which line is going where. So the red line has a balloon tip, so to make it soft and squeegee so the rectum doesn't get hurt. So I put that in the rectum and then I attach these three lines to my computer system. So there is a sensor which is the red color where I will attach the red line. There is a sensor which is blue color where I will attach bladder line, and then I attach the filling line to the drip. Okay. So what we will do now, we have nothing in the bladder, it is empty, but all these lines are air filled. So when they are air filled, they don't pick up any sensation because they can work only when they are water filled. So now with the syringe, I just put 1 ml of fluid in each of these lines so they become water filled. And then I attach them to the machine. As soon as they are water filled, they start to convey the sensation of the bladder. Okay, so now we are starting the filling phase of the urodynamics, where we will be filling the bladder 50 mils per minute. Yeah, and we will ask patient, she needs to tell us when she has the first sensation, first normal desire, strong desire, and when she is bursting to pass urine. So in the filling phase, all the lines should be flat. The vesical line, which is blue line, detrusor line, which is green line. I'll tell you how do we get detrusor line, and rectal line, which is red. Yeah. So we only put two lines, which is bladder and rectum, and filling line is only for filling. But on the screen we have three lines. The reason is, let's move on and then I'll show you a graph. So you see there in that little picture on the graph there, so there are three lines. So one line is a calculated line. So if you think about bladder, where is bladder line? It is lying inside the abdomen. So the pressure which is being monitored by rectal line, it is the abdominal pressure. Yeah, and the pressure which is coming out of vesical line, which is blue line, that is the bladder pressure. So where is detrusor present? It is present in between these two things, isn't it? Bladder cavity and abdominal cavity. This is the most important point why people don't understand urodynamics. That how do we get detrusor pressure as a calculated pressure? So please emphasize and try to understand. So we have got a rectal line coming from the rectum, which is calculating abdominal pressure. We have a blue line coming out of the bladder, which is calculating bladder pressure. So detrusor is present between the bladder cavity and abdominal cavity. So how do we get detrusor pressure? We minus abdominal pressure from vesical pressure, because bladder is also present inside the abdomen. So the detrusor pressure, in order to calculate, we take away from the vesical pressure, we take away abdominal pressure, and that is the actual calculated detrusor pressure, which is denoted by a green line which is in the middle. So two lines are coming directly from the bladder and the rectum, and third line is a calculated line, because we cannot monitor detrusor pressure directly because we are not putting any needle into the detrusor. We can only put a sensor in the cavity of the bladder and as well as abdominal cavity. So that's the reason there are three lines. And the last one shown is a flow at the voiding phase, but we will talk about it. So when we have started to fill in the filling phase, so there are two main phases of urodynamics. One is the filling phase when we are filling the bladder, and one is the voiding phase when patient gets up from the couch and sits on the same toilet again. All the lines will remain inside her. Yeah, so filling phase and voiding phase. In the filling phase, the normal purpose of detrusor muscle is to relax. So we should not have any contractions of detrusor muscle in the filling phase. But when patient is voiding, it should be other way around. Now detrusor needs to contract, so there will be a big contraction. Yeah, so that's what it is all about. So we are also noting when the patient tells us when is the first desire to void, when is the strong desire, when is the compliance, when she say, oh, I can't hold any longer, can you stop? And then involuntary contraction in the filling phase, that is the diagnosis of overactive bladder. So in the filling phase, we diagnose overactive bladder. But when we ask her to cough, after we have filled her up, then we diagnose stress incontinence. And a patient can have both. Okay, so now few definitions of the filling phase. First sensation of bladder filling, the moment the patient feels that bladder is no longer empty. First desire to void, the moment that normally patient would go to the toilet if she was at home without any hurry at the next convenient moment. Strong desire to void, when the patient would say, oh, I need to go now, I can't postpone. And then feeling of urgency, fear of leaking or pain or any other symptoms. And then every minute in the filling phase, we ask patient to cough. And why is that? So we can check the deflection on the needles, that all the pressure monitoring are equally calibrated and none of the lines has fallen out. Okay, when we look at the graph, you will understand. This is what I was talking about. Okay, so this is a typical urodynamics test, and this is a 100% normal report. Okay, so the top blue line, remember blue for bladder, that's why it is color coded as well. So that is the filling phase, and then abdominal abdominal pressure, that is filling phase, and detrusor pressure. When we take out blue from the red, the reading of the green, which is detrusor, it is also normal. Okay, so it should always be close to zero because it is subtracting each other. So that is how filling phase looks like, and then at this stage the voiding phase starts, and then there is a flow meter there. So this is the voiding phase again, when there are detrusor contraction, there big detrusor contraction when there is a voiding. And then this is another, if I point out here, up till here is a filling phase. So these are detrusor contraction. So it should be flat, but this patient has overactive bladder as well. So this is a voiding phase, this is a flow, volume, and this is a normal detrusor contraction which accompanies actual passage of urine. But up till here, there should be no detrusor contraction. But here we see vesical pressure went up, although there is no change in abdominal pressure, and there is a detrusor contraction. Because when we take out this from this, we get this. Okay? So I hope it makes sense, but it will make sense in a minute. So what do we find on detrusor function on the cystogram? Either low or poor detrusor compliance, for example, post radiotherapy. When patients have cancer treatment and they have radiotherapy, bladder becomes very small. So as soon as there is little volume of urine collected, it can start to show the detrusor pressure gradually goes up. So that is called low compliance, and steep rise in detrusor pressure in the filling phase. High detrusor pressure, like neurological causes, then the compliance will be more than high detrusor compliance. For example, if somebody has stroke or something, or spinal cord injury, and detrusor is not contracting, so it will be a very, very large filling phase. Poor detrusor accommodation, rise in detrusor pressure during filling phase, and pressure falls to normal when filling is stopped. So it is poor detrusor accommodation. That is also a sign of overactive bladder. So here we see this part. This is completely normal urodynamics. Every minute here, these are all coughs. Every minute we ask them to cough. So this shows cough, and this shows all the lines are working. Okay? So this is all completely normal. So this is the normal bladder contraction, and there is no abdominal contraction because there is no need of abdominal contraction for passing urine. And that is reflected here, which is detrusor contraction, and this is voiding phase. And this is the volume which is coming out. I'm sorry, it looks like you're not understanding. It's a bit complex. Okay, so pressure flow studies. So normal pressure flow, most important thing in this chart you need to understand is the flow rate. Okay, you don't have to worry about all the nitty gritty of it. All you need to remember, in females, if the flow is more than 15 mils per second, that's all we want. If it is like 30-40 mils, if higher, doesn't matter, but should not be lower than 15 mils per second. That's all we want. So this is a complex box about calibration of the machine, but because you don't have machine here, I think it's not applicable for you, otherwise you will get confused. Pad test. For example, if a patient is giving history, oh, she leaks all the time, but we have done urodynamics, and urodynamics has come back completely normal. So we cannot tell patient you are telling a lie. Yeah? Because in order to offer a surgical treatment, we need some evidence that there is an actual problem. So we have special pads in hospital, which we give them in airtight bags so they don't get soaked with the moisture or something. And patient uses this pad for example, 24 hours pad test or short time, and then she puts them in airtight bags and she brings them back and we measure them. And if the weight gain of the pad is more than 1 gram, it is a positive pad test. And then we can offer her treatment. Because if we offer treatment and there is a complication, then we can't justify that why did we offer her treatment. So that's the whole idea of PAD test. So this is video cystometry. It is exactly the same, but when patient is sitting on the toilet, there is X-ray machine there, and the urine, the media which we use is iodine based, so X-rays can pick it. So when she is sitting, we can see the bladder when she is passing urine on the X-ray machine. So we can visualize the functional anatomy of the bladder, and if there is any diverticula or if there is any trabecula or if there is any reflux or anything, we can actually see that. So the guidelines which we follow are RCOG, NICE and BSAC guidelines. So if you need any more references or any detail, then these are standardized guidelines. Ambulatory urodynamics, so there is a machine which we attach to the patient and there is a certain pad which is attached so that monitors it. So that is more like functional type in day-to-day activity. In my unit we don't do it, but we have it, Birmingham Women and Children Hospital, we have ambulatory. So it is a critical component of investigation for women with the lower urinary tract dysfunction and incontinence as well as voiding dysfunction. It can give us a lot of information, and this is something I have for each and every of my patients before any invasive surgery. Although some units would say pure stress incontinence or pure symptoms you can do, but for the safety and to avoid litigation, I would prefer urodynamics. Any questions? Yeah?